Management of gallbladder disease in a cirrhotic is a broad topic. In this lecture, I'll focus on the role of laparoscopic cholecystectomy in the setting of cirrhosis. The incidence of gallstones in cirrhotics is twice that of the general population, and mortality following open cholecystectomy in cirrhotics is reported to be as high as 12%. Here I'll describe our experience of laparoscopic cholecystectomy in patients with cirrhosis, and I'll also summarize two meta-analysis studies comparing laparoscopic to open cholecystectomy in cirrhotics. 10 years ago, we published in HPB our Pittsburgh series showing that cirrhosis is not a contraindication to laparoscopic cholecystectomy. Particular challenges in the setting of cirrhosis are abdominal wall varices, vascularized omental adhesions to the gallbladder and liver, and a heavy cirrhotic liver that's difficult to elevate to achieve a critical view of safety. There were 68 patients in the series with median age of 56. The pre-op LFTs were in the normal range. 69% of the patients were Child's A, 28% Child's B, and 2 patients were Child's C. It's important to do a pre-op contrast CT or MRI scan to identify abdominal wall varices as well as rule out simultaneous HCC. The most common indications for laparoscopic cholecystectomy were chronic cholecystitis or symptomatic cholelithiasis. Most of the patients were referred from our hepatology service or from the general surgeons in the community who declined to do the procedure due to the higher risks associated with cirrhosis. The median operative time was 2 hours and EBL was 25 mLs. A fifth additional port was placed in the left upper quadrant to facilitate liver retraction in 11% of patients. An advanced energy device such as TissueLink or Argon was used in 90% of patients. Pre-op transfusion with platelets or FFP was given in 5% of the patients, and a packed RBC transfusion was given in 1 patient. A JP drain was left in about a third of the patients. Conversion to open surgery was required in 4 patients. There was no 30-day mortality or acute hepatic decompensation. 1 patient experienced a post-op bioleak. There were 2 post-op UTIs, 1 pneumonia, and 1 wound infection. 4 patients spent the evening in the ICU. The median length of stay was 1 day with the longest length of stay of 13 days, and the 30-day readmission rate was 15.5%. As might be expected, compared to the Child's A cirrhotic patients, the Child's B and C cirrhotics had a longer OR time, greater blood loss, greater conversion to open cholecystectomy, longer length of stay, and increased 30-day readmission rate. Interestingly, the complication rate were similar between the Child's A and Child's B cirrhotics. This slide summarizes 2 meta-analysis studies comparing laparoscopic to open cholecystectomy in patients with cirrhosis. The first was published in British Journal of Surgery and looks at 4 randomized clinical trials comparing lap to open chole in cirrhotics. There were 115 laparoscopic cholecystectomy patients to 119 open cholecystectomy. 97% were Child's A or B. There were no deaths. The laparoscopic cholecystectomy group had less postoperative complications, shorter length of stay, and quicker return to diet. The second meta-analysis study looked at 44 series comparing laparoscopic to open cholecystectomy. The mortality was 2% in the open group, and the conversion rate in the laparoscopic patients was 5.8%, which is nearly identical to our single series 5.6% conversion rate. The overall complications, infections, and postoperative hepatic insufficiency were higher in the open cholecystectomy patients. Here are a few tips recommended for handling difficult gallbladders in cirrhotics. Get a contrast pre-op CT scan to view the liver. Look for ascites and varices and rule out hepatocellular carcinoma. Avoid excessive traction on the gallbladder during the cephalic retraction to avoid avulsion from the liver bed. Place a 5th trocar in the left upper quadrant to retract segment 4. having a first assistant as well as a camera person is very helpful because these operations are labor intensive. Use saline cooled devices for hemostasis on the gallbladder bed. Convert to open if you can't get the critical view of safety, and leave a JP drain in place post-op if there's any concern for bioleak or ascites. Importantly, if you're doing these in the community setting and you don't have good help, there's no shame in backing out and referring to a hepatobiliary specialist. In summary, the literature shows that laparoscopic cholecystectomy has less complications, infections, and length of stay versus open cholecystectomy in cirrhotic patients. Identifying patients with ascites or varices assists with pre-op planning and operative technique, and utilizing advanced laparoscopic hemostatic devices can help with hemostasis. Thank you.